So, before going to growth hormone, let us talk about hormones released by hypothalamus and pituitary gland in brief. Okay, first the hormone produced by posterior pituitary gland, that is ADH. This is the ADH. Okay, you know what the use of ADH? Antidiuretic hormone means it is not causing the diuresis. That means it is not letting down the water to go out from the body. Why? How can it act like that? This ADH hormone go to the distal convoluted tubules and act on their like we'll discuss that in obviously in the nephro, but I'm telling here. In the distal convoluted tubule we have intercalated cells and principal cells. There on the basolateral side, when it is acting on the basolateral side, aquaporin is present in the these intercalated cells go to the apical membrane and open. From there water is reabsorbed. Therefore water level in the body increases. Okay, so why there is the need to increase? Uh, how this ADH is produced? First of all, what is the stimulus for the production of this ADH? So, first, whenever there is a lack or a decrease in water in our body, what will happen? Osmolality of our blood increases. While this high osmolar blood going through the posterior pituitary gland, ADH is released in response to the osmoreceptors. Then, because of that, ADH released and acting on the distal convoluted tubule, and water is getting reabsorbed, and again osmolality comes to the normal range. But in some cases, even though there is a decreased osmolality, that is high concentration of water, also there is high production of ADH, like in case of SIADH. Why? Because in that there is a tumor syndrome of inappropriate ADH production, which is not at all responding to osmolality. Simply it is producing ADH, ADH, ADH. So there is ADH, also known as vasopressin. Then CRH. CRH is corticotropin releasing hormone. It is produced from the hypothalamus, acting on the anterior pituitary gland. What it is doing? Anterior pituitary gland further produces ECTH, but there is a pathway here known as which pathway? What pathway that is? Propiomelanotropin pathway. In this, there is production of three hormones like ACTH, MSH, and endorphin, beta endorphin, which we have already discussed here. When a person takes exogenously steroids, there is positive feedback, and there is decreased production of CRH. Okay, then dopamine. What dopamine is doing? Dopamine is not producing exactly from the hypothalamus, from the brain somewhere else. Like this dopamine acts on the anterior pituitary and causes decrease in production of TSH and the prolactin. Therefore, dopamine is also known as prolactin inhibiting factor. So, in some psychiatric conditions, we will give the patients antipsychotics. Okay, what are these antipsychotics? These antipsychotics are mostly they are dopamine antagonists. Typical antipsychotics are dopamine antagonists. This dopamine antagonist means dopamine blockers causes decrease in decrease in action of dopamine. Therefore, there is relative increase in the prolactin that causes galactorrhea in the persons taking dopamine antagonists. Growth hormone releasing hormone coming from the hypothalamus causes increasing growth hormone. There is a growth hormone releasing hormone analog known as tesmorelin, which is used to treat HIV associated lipodystrophy. Gonadotropin releasing hormone produced from the hypothalamus causes increase in FSH and LH. This FSH and LH causes um, uh, act on these FSH and LH act on the ovaries and causes ovulation and menstruation. Okay, but there is a hormone which suppresses this gonadotropin releasing hormone, that is prolactin. Therefore, if there is hyperprolactinemia, there is suppression of gonadotropin releasing hormone. So, in hyperprolactinemia, there is decrease in production of GnRH and therefore decrease in FSH and LH, therefore no ovulation and no menstruation. So, in which cases a lady is having high prolactin levels? Yes, postpartum. So, after the delivery, for few months, there is hyperprolactin levels, therefore there is decreased GnRH and decreased FSH and LH, no ovulation and no menstruation. And this GnRH based on the type of production, like continuous production or pulsatile production. Based on the type of production, there is type of action on the anterior pituitary. If there is continuous production of GnRH, initially there is increase in FSH and LH, but after some time there is decrease in production of FSH and LH, and that leads to suppression of hypothalamo pituitary gonadal axis. Okay, and if there is pulsatile release of GnRH, then it leads to puberty and fertility. Why? Because pulsatile release of GnRH increase FSH and LH. Next, MSH, melanocyte stimulating hormone, increases act on melanocytes that causes production of melanin. So, in case of Cushing's, if there is production of there is increased ACTH production, along with the ACTH there is MSH also is also produced because of pathway. What is that pathway? Pro-opio melanotropin pathway. So, in this pathway, there is increase in production of ACTH and MSH that cause hyperpigmentation, example in Cushing syndrome. Then oxytocin. Oxytocin is having two functions. One is contraction of uterus during the labor, and one more during suckling of breast by the baby, there is ejection of milk from the breast because of this oxytocin itself, and it also the hormone for love, fear, anxiety, social bonding and depression. Then prolactin. What the prolactin does? Prolactin causes, you know what the prolactin does? It stimulates the lactogenesis, means it helps in production of milk in the breast, and it also causes inhibitory action on the gonadotropin releasing hormone. We also already talked about it. Therefore, in some cases like pituitary prolactinoma, that is a tumor to the lactotropes, um, there is high prolactin levels that causes suppression of GnRH, and patient present with amenorrhea, osteoporosis and hypogonadism and the galacturia. Okay, then somatostatin. Somatostatin is also known as growth hormone inhibitory hormone. Therefore, it decreases growth hormone and thyroid stimulating hormone. Okay, uh, thyroid stimulating hormone is decreased by dopamine and also somatostatin. Remember this. Thyroid releasing hormone. It causes increase in thyroid stimulating hormone and prolactin. Okay, this thyroid releasing hormone, if there is increase in thyroid releasing hormone, along with that there is increase in production of prolactin, therefore patient present with galacturia. Okay, so now see this guys, especially this part. Sorry for the inconvenience. Okay, yeah, I know there is some problem in the camera. 1 minute. Okay, now let's talk about this. This is all these hormones are hormones from hypothalamus. All these are from anterior pituitary. So we have basophilic hormones and acidophilic hormones. B what? What's the mnemonic? Yes, B flat. Basophils, FSH, LH, ACTH and TSH. Okay, then what are the acidophilic cells? Um, Growth hormone, pig, prolactin. Okay, now you know corticotropin releasing hormone stimulate ACTH. You know that gonadotropin releasing hormone produces LH and FSH, TRH, TSH. Okay, produces TSH. Growth hormone releasing hormone produces growth hormone. Dopamine, prolactin. What causes? Dopamine is having inhibitory action on the prolactin. Okay, up to now you know everything. Now you talked about the somatostatin. What's the action of somatostatin? Inhibit growth hormone. At the same time, it also inhibit thyroid stimulating hormone. What's the action of dopamine? Inhibit prolactin. At the same time, it also inhibit thyroid stimulating hormone. Okay, you good to know that. Then prolactin. Prolactin is having stimulatory effect on the thyroid releasing hormone. Thyroid releasing hormone is having stimulatory effect on the prolactin, whereas prolactin is having inhibitory effect on the gonadotropin releasing hormone. Next, thyroid releasing hormone causes increase in production of TSH and increase in production of prolactin. Dopamine causes decrease in production of TSH and decrease in production of prolactin. So, TRH and dopamine are having opposite actions. Okay. With this, we completed the general topic of pituitary gland. Now, we'll go through each and every hormone and we'll discuss everything about anatomy, physiology and pathology. So, this is Dr. Nikita signing off. Bye.